Hello, everybody, here at the medical school and on Zoom. Today is our annual Nasrallah Rounds lecture, and our speaker is Dr. Christoph Correll. And the title of his presentation is Cardiometabolic Risk and Schizophrenia, Etiology, Monitoring, and Management. And I'd like to give a longer introduction to Christoph, but first I just wanted to make a few general points about the Grand Rounds. One is for people on Zoom today, your microphones will be turned off and camera as well. So that's just normal. We do hope that people have questions and comments near the end. And the way to communicate those is to put them in the Q&A box at the bottom of your screen. Please don't use the chat box, because that's really just for the panel here and the interpreters. And also, we'd like people to fill out the evaluation at the end. And there'll be a link to it that'll come up on the screen, and it will be in the chat at the very end as well. For those of you leaving here, there should be a QR code on the door that you can just scan with your phone to get to it. Okay, now that we got that out of the way, it's my pleasure to introduce Dr. Christoph Correll, whose work I've really found important and interesting for a long time. Dr. Correll is currently a professor of psychiatry at the Zucker School of Medicine at Hofstra and at Northwell system in New York City, and also professor and chair of the Department of Child and Adolescent Psychiatry at the Charité University School of Medicine in Berlin, Germany. He completed his medical school work at the Free University of Berlin and also at Dundee University in Scotland. He's board certified in general psychiatry and in child and adolescent psychiatry, and completed both of those residencies at the Zucker Hillside Hospital in New York City. Since 1997, he's been working and conducting research in New York, and since 2017, he's been in Berlin at the Charité as well. Dr. Correll's work focuses on the early identification and treatment of youth and adults with severe mental illness, clinical trials, epidemiology, psychopharmacology, meta-analyses, and the interface between physical health and mental health, which is something he'll be speaking about today. He's published over 800 journal articles, which is astounding, especially for someone as young as him. And these have been cited more than 63,000 times. He's received over 40 national and international research awards. And as of this month, his H index on Google Scholar was 132. And what that means is that he's had 102 papers among his over 800. 132 of them have been cited at least 132 times. So these are very, very difficult statistics to reach. And he's also been listed every year since this began in 2014 by Clarivate Web of Science as one of the most influential scientific minds and one of the top 1% cited scientists in the area, in the field of psychiatry. I mentioned before, Dr. Correll's work's in a very important area, and it's very relevant to what we do here in this department, where there's such a focus on medicine and psychiatry and working with people with both medical illnesses and psychiatric illness. His work with diabetes, that we'll hear about today, is particularly important because, as many of you may know, people with psychotic disorders tend to die on average about 20 years before their age-matched peers. And a lot of that is due to comorbid medical conditions, such as cardiovascular disease and metabolic problems. I want to thank Dr. Correll for joining us today, not only giving this lecture, but also as the Nasrallah lecturer. He's been meeting with people on our faculty interested in this work, and we'll have additional meetings after his presentation today. And so it's really great that he was able to share his expertise and experience with our group and give feedback to also what we're doing here. I also wanted to say to Christoph that Henry Nasrallah, who is responsible for this endowed lectureship, normally comes to these, but he can't today because he's hosting his own grand rounds at, in Cincinnati. But he wanted me to make sure I said hello to you from him, and he's going to watch the recording. So anyway, let's give a warm welcome to Dr. Christoph Correll, and hope there'll be a good discussion at the end.
Great. Thanks very much, Steve, for the very kind introduction and also the invitation. And I'm obviously extremely honored to have been selected to be a Henry Nasrallah lecturer this year. And also I'm honored because I know Henry well and also really respect his work. And hopefully today I can give a little bit back to the community that is listening today so that you can have food for thought, maybe food for research, but also clinical work. And since I know you're doing quite sophisticated work in the department, I also know that many of the viewers will be in the trenches. So I kept this a little bit more clinical. Obviously, during the discussion section, I'll be happy to also go more into the weeds of research. And I've already had a chance to talk to Joyce today, and we'll talk to others later after the grand rounds to deepen that route. You've already seen the disclosure. I flash it up again. I'm happy and proud to be able to work with a number of companies that are still operant in the brain. Many have left because it's very difficult to bring new treatments into our hands. And at the end, I'll talk about some novel developments and as they pertain to cardiometabolic risk in people with psychotic disorders. Here are the 4 chapters that I will be covering before having time for discussion. So what are the cardiometabolic abnormalities in schizophrenia? What are the effects of treatments on body composition and metabolic status? What is the interaction and intersection between cardiometabolic abnormalities and psychiatric outcomes in schizophrenia? And what should we do about it? Let's start with this blueprint article that's already 4 years old. It's amazing how fast time passes. This has been cited, I think, almost over 1,000 times already. It was a group of us coming together, laying out the land. What do we need to do to protect physical health in people with mental illness? And what are the issues? And on this slide that is coming directly from this article, you see that there are on the left-hand side, upper quadrant, the issues with elevated risk factors that lead to premature mortality, as Steve has already mentioned, 15 to 20 years, especially people with schizophrenia. Suboptimal prescribing practices, suboptimal monitoring of side effects, although both the medication and the illness are risk factors. The monitoring for metabolic abnormalities is not higher generally than in people without antipsychotics and without schizophrenia or mental illness, which is really mind-boggling. There's also inadequate health promotion that could help people to have better lifestyle. On the right-hand side, health policy is not good enough in order to deal with all of this. We need to improve, obviously, the prescribing and also have research digital technologies to help promote physical health. So there are solutions to these 3 problems, and we need to engage in them more. But then at the bottom, you see also that our healthcare system, especially in the United States, is quite fragmented. And that also leads to disintegration of healthcare. And we've also contributed some meta-analyses that I'll show one of at the very end. So there are issues, but there are issues we can address. We just have to do it together. And to highlight what people with severe mental illness deal with, I'm showing these 2 slides from the big multinational study that looked at both years lived with disability and also mortality, shortened life. And you can see in red mental disorders, and they actually have the onset early in life, especially also psychotic disorders. Basically, 2/3 have been declared by the age of 24. 50% have been diagnosed by the age of 18. If you look at all all psychotic disorders together. So it's an early onset that interferes with developmental milestones, with having social interactions, work, education, all the things that make us human and want to live and have sense in life and agency. But at the same time, not only at the entry into life, but as we get older, what really causes the most disability-adjusted life years shifts from mental illness in terms of proportion to cardiovascular and circulatory diseases. And that is shifted earlier in people with severe mental illness. So we have, in a way, a sandwich effect: early mental illness and earlier cardiovascular illness. And people are then squished between the two. That means we need early recognition of mental disorders and intervention for that. And we need early recognition and prevention of cardiovascular disorders, as well as intervention. And why are people with severe mental illness at a higher risk of dying early? Well, here are the burden of disease attributable 20 leading risk factors. And you can see the ones I highlighted in red are all higher in severe mentally ill patients, including and especially in people with schizophrenia. High blood pressure, smoking, substance use, low intake of fruits, high blood pressure, high body mass index and fasting glucose, low physical activity, high cholesterol, low intake of whole grains and vegetables, and omega-3 fatty acids. So these are preventable issues, and we need to also do this very early in schools so that we have primary prevention. Now, for some, this might be very basic, but again, assuming that not everyone is deeply into cardiometabolic illness in the mentally ill, I'm showing a couple of basic slides just to understand insulin resistance is at the core of what we want to avoid. It's fueled by overweight and obesity, but also genetics, older age and inactivity. There are problems with family history, so genetic risk there, smoking. And this then expresses itself, the insulin resistance, or is related to hypertension. But what we measure as our cardiovascular risk factors and what is part of the metabolic syndrome, so glucose, lipids, hypertension, and body weight, is all due to the Framingham study. This is what we had and where we have very nice calculations. We know that there are much more proximal risk factors for cardiovascular illness and atherosclerosis, and these include subfractions of dyslipidemia, include endothelial dysfunction markers, impaired thrombolysis markers, and inflammatory markers. But since these were not included in the early studies, they're not included yet in these risk calculators. And again, a very old study just showing why the metabolic syndrome was actually created, because these risk factors are not additive. They actually are hyperbolic, exponential. You see here each one risk factor, whether it's higher BMI or smoking, and when you add them together, you don't get with 5 risk factors, not 5-fold increased risk. It's actually 12-fold increased. Clearly, we need to address each and every of them in order to reduce the risk. Just to get us all anchored, what is metabolic syndrome? We currently in the US use the ATP3A criteria. So it's either increased waist circumference, but that's hard to measure. Many of us use just obesity, a BMI of at least 30. It's elevated blood pressure, not 140/90, which is full-blown high blood pressure. It's already sub-threshold high blood pressure. It's low HDL cholesterol, less than 40 in males, less than 50 in females, which is a protective item. It's high triglycerides, but again, in a lower range than abnormality, it's 150 at least. And glucose was lowered from 110 to even 100, bearing in mind that the threshold for diabetes is 126. Now, why do people with mental illness, or in this case, schizophrenia, die prematurely? And here, this is a very nice early study by Mark Terhert that makes it really palpable. On the upper frame, you see metabolic syndrome risk according to illness duration. And the longer people are ill, the higher the rate of metabolic syndrome. Now, you could say this is really lame, because what is the most predictable risk factor of death and of metabolic syndrome? Well, let me break the news to you. It's age. The older you get, the closer you get to death. The older you get, the more pounds you put on. So in that sense, this could be just aging and putting on weight. But the lower panel actually gives you the secret, why people with schizophrenia die early. So here, Mark Terhert and his team compared the metabolic syndrome risk against the people in the same country, in Belgium. Healthy controls, general population, relatively young, 35 to less than 45. They appropriately have a low metabolic syndrome rate, less than 7%. But look at these relatively young schizophrenia affected patients. They actually have an almost 500% greater risk of metabolic syndrome. Wow. Early in life, when usually our cardiovascular health is pretty good. Now let's fast forward this by 10 years. Everybody gets 10 years older. In the general population, actually the metabolic syndrome risk doubles from 6.5 to 14%. But what happens in schizophrenia? It's almost saturated with almost a ceiling effect. Here, there's basically a 10% or a 15% increase. So that means we're shifting the cardiometabolic burden and risk early in life. So the system is affected by these risk factors much longer, which shaves off life expectancy. But weight is extremely important. This is again an earlier study when people only thought that, oh, metabolic syndrome, antipsychotics, this is a problem in people with schizophrenia. We did an early study looking at everybody admitted to the hospital and doing careful cardiometabolic monitoring, everybody being on a second-generation antipsychotic. And you see, whether it's bipolar disorder or schizophrenia, same risk of metabolic syndrome, over 40%. But then look at what happens between healthy weight, overweight, and obese. This is an enormous increase from 1 in 5 to almost 1 in 2 to 3 out of 4 patients. So keeping down the body weight is really important. But it's not just weight. There are also weight-independent effects. So these are data from the RAISE study, the Recovery After an Initial Schizophrenia Episode study, NIMH-funded, where at baseline, we assessed these young folks, mean age was about 23, and found a dyslipidemia rate of almost 60%. They had on average 7 weeks of antipsychotic exposure. These were first episode patients within the first 6 months of treatment. We also found high blood pressure and even diabetes rates that early that are clearly higher than what we've seen in the general population, including a metabolic syndrome rate of 13% in these very young folks. So we found that the total illness duration was related to higher body mass index, fat mass, fat percentage, waist circumference, but not with elevated metabolic parameters. So maybe the prodrome, the duration of illness, of even comorbid diseases, makes you put on some body fat and body weight. But antipsychotic treatments seem to drive this even further, significantly with higher non-HDL cholesterol, triglyceride, and triglyceride HDL ratio, and lower HDL cholesterol, as well as systolic blood pressure. Olanzapine was clearly the worst offender. There were sex and racial differences concordant with general population data. So there seemed to be, despite similar obesity frequency than in the general population, there were smoking and metabolic syndrome were more common. Dyslipidemia and prehypertension were similar only to the general population 16 to 20 years older. So again, what Mark DeHert showed 8 years before, we were able to show in the US too. The risk factor profile means you're not dementia precox, it's metabolic dementia precox in people with schizophrenia. This was being shown also meta-analytically, that people with first episode and unmedicated patients obviously are not as worse off as people who are chronically ill and who have metabolic treatments or abnormal treatments that can adversely affect metabolic outcome. But we also know that basically our first episode patients are worse off than the general population. We then did a meta-analysis pooling together individual meta-analyses across schizophrenia, bipolar disorder, and depression, showing they're pretty similar. Severe mental illness is associated with metabolic syndrome. But there are either genetic or behavioral differences. Here, we looked at differences of metabolic syndrome rate in these severely mentally ill patients across different regions. And you can see how different the rates actually are, between 1 in 4 to 1 in 2. And the US is on the upper tertile with 1 in 3 people. But the question is, when does it start? So Toby Pillinger from Oliver House Group in London has looked at patients who were antipsychotic naive and found that in both fasting glucose and oral glucose tolerance parameters, these patients had significantly worse outcomes or status than healthy controls. It was a small effect size, 0.2. Remember, 0.2 is small, 0.5 is medium, 0.8 is large for fasting glucose. That makes sense because fasting glucose is the last thing that goes. The insulin receptors in the liver that is responsible for regulating fasting glucose they are very sensitive. Oral glucose tolerance test, though, which also looks at postprandial glucose excursions. So here we have the muscle insulin receptors that transport after food the glucose into the muscle, out of the blood. When that is interfered with, you see early signs of prediabetes. So here the effect size was 0.61, which is moderate, worse for patients antipsychotic naive with schizophrenia than healthy controls. Looking at fasting insulin and HOMA-IR, a measure of insulin resistance, were in the small to medium effect size. Now, is this really related to the genetics of people with schizophrenia? Is it shared environment with other people in the family who also have poor healthy lifestyle? Is it low socioeconomic class? Is it prior illness interfering with healthy lifestyle? It's unclear, but it's most likely a web of each of those factors. But Toby Pillinger has also looked at schizophrenia, coining it a multi-system disease. And it's fascinating. When you look at, in a meta-analytic way, at the top, the CNS effect sizes for abnormalities in brain structure, first episode versus controls, a 0.4 effect size. Neurophysiology, 0.8, neurochemistry, 0.4. So overall, the CNS differences between people with schizophrenia and healthy controls is about 0.4, a medium-sized effect size. But look at the left-hand side. When looking at non-CNS peripheral differences to general population controls, we have about 0.2 of cardiometabolic disturbances, 0.7 for stress axis cortisol, which might also drive some of the metabolic abnormalities, and immune disturbances even larger, 1.2, pooled together being even higher with 0.58 for extra CNS abnormalities compared to CNS abnormalities. Now that raises the question, how do these relate to each other, CNS and non-CNS abnormalities? And there are obviously three main hypotheses that are listed here. Model one could be there is a risk factor that drives non-CNS dysfunction, which then gives rise to non-CNS disorders and secondarily to CNS dysfunction. The second model is there is a risk factor the opposite way. It goes predominantly for CNS dysfunction, and then that leads to non-CNS disorders because of behavior or other psychosis-related issues. And the final model would be that there are risk factors for both that are shared or separate that give rise to CNS and non-CNS abnormalities. Be it as it may, we need to monitor and address both, because both CNS and non-CNS abnormalities interfere with people's functioning, quality of life, well-being, and longevity. Where do our treatments fit into this? This is from a paper where we try to put this together, maybe on paper complex model, but it's not that complex. So we have genetic underlying tendencies that make you at a higher risk for either diabetes, hypertension, weight gain, and also obviously psychosis. And we have drugs that interact with this genetic effect, giving rise to maybe changes in neuropeptides, neurotransmitters. But this is then moderated by baseline factors, which setting of treatment, which illness, what are the co-medications or medications, the diet, activity, and BMI. And via the effect on the illness or the medication itself, we have also mediating factors. Co-medications might need to be added or stopped. Adverse effects like sedation or EPS might reduce activity levels. And there are dietary and activity changes based on the medication. You could obviously study this interaction at each of those levels, and the more levels you look at, the more precise your model will be. There are differences, clearly differences among antipsychotics and their weight gain potential. The penes at the bottom, olanzapine, quetiapine, chlorpromazine, clozapine, all have histaminergic blockade, which has been associated with weight gain quite a bit. So they are the most away from the vertical line, which is placebo. Higher up and without crossing that vertical line, you have less abnormality. So on top, we have ziprasidone, lurazidone, the PIPs, aripiprazole, brexpiprazole, cariprazine, as well as high-potency first-generation agents that obviously have other issues like EPS and tardive dyskinesia. But what really drives the ill effect on longevity is the metabolic burden. And here's a heat map, again, from Toby Pillinger and his group. And you see the same medications I mentioned as having less weight gain also being less red, less toxic across the glucose and lipid parameters. So they co-segregate quite a bit. Olanzapine and clozapine are the worst offenders. And we now know that it's not just a weight effect. There's also a weight-independent effect, molecular effect, that after one dose can alter the oral glucose tolerance test, both with clozapine and olanzapine. So here we looked at differences of medications and metabolic syndrome risk, and there are differences where, again, significantly greater risk with olanzapine, clozapine, and quetiapine, as well as risperidone, and lower risk with typical antipsychotics aripiprazole. So your choice of medication will make a difference in the risk that patients are experiencing. And these are data from our recent analysis of mortality. People with schizophrenia have a threefold increase of all-cause mortality. Relative to the general population, this goes up to tenfold for suicide. In patients with first episode in early phase illness, the risk is not threefold, pooled together it's sevenfold. A lot of it is suicide, but also we have mortality from disorders that should happen much later, including cardiovascular illness, which is obviously the greatest contributor in terms of volume, in terms of who will die with schizophrenia. Although antipsychotics, as I just mentioned, can worsen cardiometabolic status, there is something that's almost like an antipsychotic paradox. Because when we analyzed contributors or mitigating factors for mortality, clearly antipsychotics reduce both all-cause mortality, mortality from suicide, but also mortality from natural causes, meaning they reduce the risk of mortality from cardiovascular illness, even though they can increase risk factors for cardiovascular illness. Why is that? And by the way, it's mostly long-acting injectables for non-refractory patients because people are on the medication that reduce the risk of death, and it is clozapine for refractory patients. Well, although antipsychotics can contribute weight gain, metabolic burden, they also reduce psychotic stress. So as you're not as worried about being killed, as you're doing better with your symptoms, both cortisol goes down, but also your healthy lifestyle goes up. And we looked at that in the Finnish database, we were able to show that in a within subject analysis, so the same patients were followed being either on antipsychotics or off antipsychotics. When they were on antipsychotics, they were much more likely to also be on secondary prevention for cardiovascular illness. Less statin discontinuation, less antidiabetic discontinuation, less antihypertensive discontinuation, less beta blocker discontinuation. And again, like for mortality overall, clozapine and LAIs did better in reducing the risk of cardiovascular illness medication discontinuation. Now, clozapine has obviously the advantage that we're looking at these patients every week for the first 6 months, every 2 weeks thereafter, and then every month for the rest of their life, that we're drawing blood for levels where we can easily tag on also lipids and glucose. So monitoring may also be increased in these patients, even though they are more severely ill and have higher cardiometabolic burden. So how do then the cardiometabolic abnormalities relate to outcome? Here is a study of 435 people with schizophrenia, where they were asked on a scale from 0 to 100, how much does a certain side effect interfere with your well-being, and in this case, actually functioning? And you can see whether that's sedating side effects, activating side effects, or weight gain and sexual side effects. The interference is in the high 50s to high 60s. And actually weight gain had the highest interference with functioning, not just self-image and well-being. And here's a meta-analysis we published 2 years ago, showing that like in the general population, people with schizophrenia who also have metabolic syndrome, diabetes, or hypertension were at a higher risk of having impaired cognitive function compared to people with schizophrenia who do not have these impairments. So by improving cardiometabolic status, you're not worsening, maybe even can improve cognition. By allowing cardiometabolic burden, you're allowing to worsen cognitive status even more than is already problematic in people with schizophrenia. And there may be an association between the risk for schizophrenia, that is the polygenic risk score, that is obviously higher in people with schizophrenia than in general population, as well as HOMA-IR. And interestingly, in this study, they were also able to show that those with a higher polygenic risk score had also, and a higher HOMA-IR, so that is insulin resistance, had a higher risk of switching, meaning not doing as well. So insulin dysregulation may be related to poorer antipsychotic response. Now, is that because these patients had already failed more treatments? But these are first episode naive patients. So I think we need to take this at least as one piece of the puzzle, that insulin dysregulation, risk for schizophrenia, and poor treatment response may have a relationship. Another relationship, again in first episode patients, is between weight gain and brain health. So here, for each BMI point that was gained, there was 1 month per year greater brain age. So that means if you have like 5, 6 points and 10, 20 years, that is a lot of years lost, a lot of months in the brain. That is almost 100 months, what I just calculated, that you're older. So we need to bear that in mind. And again, even for us, try to reduce body weight, but especially for patients who are much more vulnerable to preempted brain aging because of inflammation, substance use, the illness itself, and other poor healthy lifestyle behaviors. So what should we do about it? Well, first of all, we need to monitor. And monitoring includes both the family and personal history, what the lifestyle is, reinforcing positive lifestyle, measuring height and weight. In kids, you want BMI percentiles and Z-scores, which are normed for age and development. Look for somnolence and sedation and EPS, which can actually interfere with healthy lifestyle. Sexual symptoms and signs, because that might give you also non-adherence. Blood pressure and pulse, maybe every 3 to 6 months. Fasting glucose. In the beginning, we thought glucose and lipids are enough. But now that hemoglobin A1C is not just a measure of monitoring for diabetes patients, but also an identifying variable, diagnostic variable for pre-diabetes and diabetes, we should measure that also. And it has the benefit that it's independent of fasting status and that it covers the last 3 months. In high-risk patients, I mean, you should always measure baseline at 3 months, which is the early change that may be most relevant. But in high-risk patients that have a family history of diabetes, that are obese, you might actually do 6-monthly testing instead of 12-monthly testing. Plus, whenever there's a 7% weight gain, do another metabolic assessment, because 7% is a real problem. The other parameters have to do with antipsychotics themselves, liver function, EPS, tardive dyskinesia, electrolytes, prolactin when there's symptomatic status. EKG only when you're concerned about cardiometabolic status in the family, long QT syndrome, or when you switch to longer QT drugs like clozapine or ziprasidone. Obviously, when we admit people, we always do an EKG to have a baseline. We want to keep people in the green range, absolutely. And when they're in yellow or red, we need to do something about it. We shouldn't just say, oh, this is part of the illness and duck and cover. So it's not just screen, we also need to intervene, especially in people in the red zone but also intensify healthy lifestyle interventions and education when they're in the yellow zone. Because lowering risk factors for cardiovascular illness really have an effect. Now, these are data from different studies. You can't directly compare them, but it gives you an estimate of the size of the effect. So every BMI point decrease gives you maybe an 8% decrease in coronary heart disease risk. Going down when you have hypertension by 6 millimeter mercury, maybe 16%. Here you see about a third risk reduction if you reduce weight by 4 to 10 kilograms, reduce the total cholesterol by 10%, but also for each milligram per deciliter LDL cholesterol decrease, you get 1% decrease of coronary heart disease risk. And the opposite may be true when you increase LDL cholesterol. But the biggest effects are a healthy weight, 18.5 to 25 BMI, active lifestyle. Even just a 20-minute walk can be helpful. Even if you don't lose weight, this activity already reduces insulin resistance. And smoking cessation. Some of the healthy instruction might be unknown to patients. Sugar-containing drinks are bad, but even diet drinks are bad because they're sweet. And sweetness means to the brain, since millions of years, there is a carbohydrate. I need to crank out preemptively insulin. So insulin response goes up, even though the calorie is zero in zero-calorie drinks, and the next meal is larger. Also, mastication, chewing is relevant to count calories. If you have the same calories in a liquid, you have more appetite the next meal. Even if it's a thick soup, it's more appetite and more caloric intake than when you have something that you chew on. Obviously, less sedentary behavior, less fast food, all helpful. What have been in the meta-analysis we published a couple of years ago in World Psychiatry, the ways to reduce cardiometabolic risk, in this case, weight gain? Well, definitely large effects for individual lifestyle counseling and exercise intervention, as well as psychoeducation, medium effect. But this is in patients who are compliant, who want to be in these studies. We did a meta-analysis looking at more comprehensive patients that didn't select. There, the effects were relatively small of non-pharmacologic interventions. Aripiprazole augmentation only for clozapine and olanzapine. Topiramate can be helpful. Also, GLP-1 receptor agonist. Here it says small. Since we now have semaglutide and not just liraglutide, where we also contributed an RCT and a meta-analysis, semaglutide has enormous effect sizes, and we're currently conducting a study in antipsychotic treated people with schizophrenia in Denmark, and there are 2 other studies ongoing. This may actually be the way to go, but not orally. Do it subcutaneously as an injection, because otherwise you have to have no more than 120 milliliters of liquid, and it has to be 30 minutes fasting before you eat afterwards. It's complicated. Many of the other treatments are not effective. This is the only study that compared actually switching to augmenting. This is metformin versus switching, and both had similar effects for weight reduction. Metformin is certainly something that can be used, but it doesn't always have very strong effect sizes. I want to finish up before we have questions with some novel treatments. Lumateperone, most likely the cardiometabolically safest drug that in an open label switch study showed after only 6 weeks a significant reduction when coming from usual care agents on LDL cholesterol, insulin, total cholesterol, weight, and triglycerides. Then, after 6 weeks, lumateperone was stopped, and people went over in 80% to their old drug, and all of the gains were lost. So it's a de-challenge, re-challenge study showing that very quickly you can improve cardiometabolic parameters with one of the newer agents. This was not only shown at 6 weeks, but we also showed that at 1 year, not yet published, where at least LDL and total cholesterol also reduced without compromising total PANS. Then you may have seen the olanzapine-samidorphan combination. So it's a mu-opioid antagonist that interferes with the food-reinforcing opioid release when we eat. In the first phase 2 study that we conducted, there was a significant effect compared to olanzapine, but after a lag time of about 4 to 6 weeks. But when patients were then switched over long-term, there was no further weight gain after the 12 weeks. The difference was greater in patients who had weight gain in the first week lead-in period. This was followed up by a phase 3 study leading to FDA approval. And again, after a lag time of 4 to 6 weeks, almost sealing the deal, no further weight gain with olanzapine over 6 months versus olanzapine itself did have weight gain without the samidorphan. Now, olanzapine-samidorphan combination still has weight gain. It's about 4% rather than 6.5% of weight gain, 3 kilograms at 6 months versus 5. Yes, not 30% gain 10%, only 18%. Not 43% gain 7%, but still 28%. Nevertheless, when wanting to use olanzapine, you're cutting the risk of weight gain in half. So the odds ratio is 0.5. We're also able to show an odds ratio decrease for waist circumference of 5 centimeter increase. And in a separate analysis, in patients who had not have metabolic syndrome or hypertension, the incidence was also reduced by half. And that can be seen in this graph of a study published this month. But I want to finish up with 5 agents that are in development. Ulotaront, a TAR1 agonist that has shown efficacy for schizophrenia. No D2 binding, no cardiometabolic signal at all. Xanomeline and trospium, an M1, M4 muscarinic agonist, 3 positive studies. It will be approved, our first non-postsynaptic dopamine blocking antipsychotic in schizophrenia, either late this year or first half next year. It has other side effects, pro and anticholinergic, because an anticholinergic was added to counter some of the M1 related procholinergic side effects. No cardiometabolic burden. The follow-on agent, emraclidine, which is an M4 positive allosteric modulator, also no cardiometabolic effects. All these 3 are tested for total symptoms. And ulotaront and emraclidine have each 1 positive study. Xanomeline, trospium, KarXT has 3 positive studies. Effect size of 0.75, 0.61, and 0.60. So quite respectable. Pimavanserin is currently studied for negative symptoms, approved for Parkinson's psychosis, no cardiometabolic side effects. And iclepertin, studied as a glycine transporter 1 inhibitor for cognition, also no cardiovascular side effects. So if any of these become available, we have agents where we don't expect any cardiometabolic burden. So let me stop here to give us time for questions. People with severe mental illness, particularly with schizophrenia, have a high risk of metabolic syndrome and cardiometabolic abnormalities and mortality. The risk is certainly conferred by a web of multiple factors, mental illness, unhealthy lifestyle, also our treatments, although our treatments can also reduce cardiometabolic burden. There are predictable cardiometabolic side effects that we can grade based on what we choose to treat. And there are effects on both physical and mental health. And clearly, I didn't have time to show that, but collaborative care is the way to go. And even Buddha, many, many years ago, knew to keep the body in good health is a duty. Otherwise, we shall not be able to keep our mind strong and clear. Thank you for your attention, and I look forward to your questions.
Thank you, Christoph. That was really great and a lot of information there. That's can be translated today into some improvements in practice. So we have some questions. I'm going to start with one that came in from Zoom. And this question is, how much do you feel is the role of psychiatrists in managing diabetes and addressing prevention of diabetes and cardiovascular disease? Or how do we get internists and primary care buy-in to help us address this?
Yeah, in the interest of time, unfortunately, I didn't enlarge that chapter, but I think it's collaborative care. I mean, most of the time, patients see us and no one else. So we need to educate them on healthy lifestyle. We need to select treatments that are less cardiometabolically toxic, and we need to monitor. Without monitoring, we have really lost the ability to do primary or early secondary prevention. And once we have an issue, I don't expect psychiatrists to know the latest and the greatest on diabetes and hypertension treatment. Then we need to refer. But I think we should be the ones to orchestrate care. Like when somebody has extrapyramidal side effects, we don't send them to a neurologist right away. We actually try to deal with that side effect. And we can do that with metformin. Metformin is very easy to use when we see weight gain, likely better in the early phase of weight gain, as with olanzapine samidorphan. It reduces weight gain, it doesn't reverse it. And now with semaglutide being really approved for diabetes, but also for weight abnormalities in adults, in adolescents, it will have the same effect in people with schizophrenia and antipsychotics. So that's easy to prescribe, and we should consider, if patients don't go to the primary care physician or internist, to also take on that extra prescribing.
Okay, thanks. We have a question from someone in the back.
Thank you so much for your presentation. I was wondering if you have any insights regarding prophylactic treatment in patients that already have, for example, 1 or 2 side effects. Do you recommend starting treatment for someone who is obese, for example, or already has hyperlipidemia and presented for psychosis and is going to be started on an antipsychotic?
Prophylactic treatment with what?
With metformin or the GLP-1, for example.
Yeah, I mean, I think most clinicians would say first, do no harm. So try to have healthy lifestyle instruction and have them engage in some lifestyle program, but don't wait too long. If you then see in the first month and you start an antipsychotic that there's weight gain, early response predicts later response. Within a month, I would then start metformin as a preventive agent, but not day one. Patients have enough to grapple with to understand that they now have to take one medication, but monitor them. And as you say, if they already have a risk factor, afterwards, you might then address that. If it's really severe, then a statin might need to be given. And if the healthy lifestyle instruction doesn't help, then I think having pharmacologic augmentation should be really considered.
Thank you.
Okay, we have another question online here. This is, you mentioned brain health. Have you investigated the increased rates of dementia in those with psychotic disorders? Of course, obesity, diabetes, et cetera, would drive up those rates, but just wondering about antipsychotics, in particular, those with notable anticholinergic effects.
Yeah, I'm not sure there's consistent data to suggest that antipsychotics would increase the risk of dementia. If anything, I would say if we see that they are associated with better cardiometabolic health outcomes because of secondary prevention, maybe less psychotic stress, they might actually prevent somewhat against dementia. But that's an interesting question to investigate, absolutely.
Okay, thanks. Okay, another question. Can you speak further about EKG monitoring frequency and QTC prolongation?
Yeah, I mean, I don't think it's a mandatory assessment when you start any drug that doesn't have QT prolongation on its shoulder. So clozapine, you should do it definitely. Ziprasidone, and if it becomes available, maybe amisulpride, Sertindol are the main offenders. If you have someone who's on other QT prolonging medications, then you can also do it. But a baseline generally suffices if it's normal. If you have a QT prolonging agent, then I would do another QTc assessment at steady state of the drug. And then if it's normal, don't do it anymore because there shouldn't be any change.
Okay. I think we have time for one more question. Anyone here?
Well, there are two more I can very quickly say, do health differences seen in schizophrenia apply to schizoaffective disorder and bipolar disorder? Yes. Would you comment on what's data showing weight gain in children and adolescents with risperidone Abilify? Well, weight gain early on is higher in these patients, even with our aripiprazole. There doesn't seem to be a totally weight neutral drug. But in our study, at least, we showed that there's less metabolic burden with our aripiprazole than risperidone. But risperidone even less than with quetiapine or olanzapine. And we just recently published in World Psychiatry that even low doses of quetiapine, 25 to 50, used for anxiety in a nationwide baseline database study in Denmark, showed greater cardiovascular illness and myocardial infarction and so forth. So even low dose quetiapine is not inert.
Okay. Just maybe we'll comment on this one last point from someone who also works in this area. She's saying, as an endocrinologist, I have to admit that GLP analogs and incretin analogs are extremely promising, but often not covered by insurance for obesity plus minus prediabetes, which emphasizes early and aggressive screening for diabetes.
Yeah, I totally agree. And I think we need to push back. And if we do, I think insurance companies would have to cover it because it's now approved also for non-diabetic diabetes patients with obesity. So I don't see a real reason that they can deny it. And it's even approved also, or the study is out at least for adolescents.
Okay, so we're about out of time. I think we may email you a couple of last questions just to get your thoughts. So this was great. It was really informative. And I'm so glad you've agreed to meet with some other faculty this afternoon. And we may call on you for wisdom at some other point in the future as we develop our medicine and psychiatry programs here. So thank you again, Christoph. And thank you all for coming here today.
Thank you for having me. And yeah, it's been a pleasure and I would love to come back. Take care.
Okay, bye.
Bye.